A couple of months ago, we thought we were finished with doing these updates because we were on the home stretch and summer was good and we were enjoying that. And now things have changed a lot. So there's a lot to talk about today, unfortunately. And it's all about, the upsurge in COVID, particularly this Delta variant that is running rampant in the US as well as here in Massachusetts. Following the daily case rate, last Friday we were up to 1,100 per day, which is looking a lot like the epidemic, last spring, and in some states, particularly with low vaccination rates, it's just really out of control. As Dr. Rochelle Walensky, director of CDC, points out, this is largely an epidemic of the unvaccinated. So right now, particularly those people who are ill, it's 97% unvaccinated. So yes, while the newspapers are highlighting the close to 8,000 breakthrough cases that we've had here in Massachusetts, that's still less than 0.2% or 2 per thousand of those of us who have been vaccinated who have had a breakthrough infection. And the good news there is that the vaccine is particularly effective at preventing serious illness. So most cases that have been occurring as breakthroughs are mild. And the Provincetown cluster that was studied intensively by the Department of Public Health and CDC gives credence to that, and has also resulted in some new guidance from CDC about masks for those of us who are vaccinated. But let me get to one of these overarching and important questions that Amy kindly sent from our members. I'll read it in length because it touches on a number of points. For the 65 and over vaccinated population, how will we know when our immunity is significantly waning and a booster is needed? Is there any urgent agency studying the antibody status of the 65 plus population who got vaccinated earlier this year? It seems to me we could get into some very catastrophic waters with Delta if the immunity of 65 plus vaccinated people all starts to wane at about the same period post-vaccination. And once again, the virus, and now with a deadlier version of the virus, takes hold in the older population, there could be a lot of infection, hospitalization, and death. Well, the good news answer to that is in part that the hospitalization and death part isn't likely to happen. And that's because rather than following the antibody status, which is declining among us, and Pfizer estimates that it's about 6% decline every 2 months. So that those of us who have now been vaccinated a good 6 months ago, the effectiveness of the Pfizer vaccine, which started out at 94, 96% in the clinical trials, is now down to about 84%. So why is this still good news? And the answer is that rather than looking at the antibodies status going down, which is declining, and many of us perhaps may not have very many antibodies circulating now, the immune system remembers the effect of the vaccination, and particularly different cell lines, particularly the B cells, are sitting there still waiting for the next offender to come by and quickly making antibodies. And there's other T cells that are also much a part of this rather complex immune system that we all have, that also contribute to neutralizing the virus. So while infections can occur, breakthrough infections, particularly the more serious aspect, and this Delta virus seems to have the ability to take off quickly very often, through the upper respiratory system. But for lung infections, which is what puts people in the hospital, that takes a bit longer, and the immune system has a chance to kick into high gear and overcome the virus. So, for example, in this Provincetown recent cluster and outbreak in July, of the 439 people who got infected, 75% of those were breakthrough infections of people who are already vaccinated, but only 4, which is less than 1%, had a hospitalization. So the vaccine is doing its job in terms of keeping us out of hospital and from becoming seriously ill. But coming back to the earlier part of this question, when should how should I know when a booster is needed? Well, I think the short answer to that, take the booster shot as soon as it is offered. And you'll be happy to know, perhaps, that the CDC Advisory Committee on Immunization Practices is meeting this Friday to consider booster shots for particularly immune-compromised people, those with cancer or some condition they're taking drugs that suppress the immune system. Those people have not had a very robust response to the vaccines, and a booster shot really does ramp it up considerably. So they may be the first in line to get booster shots, and we may be seeing news even in the next week or two. It wouldn't be surprising. So there may be certain populations starting to get booster shots, perhaps as early as September, depending on how fast the wheels of the bureaucracy turn. Many of you might be saying, well, if it looks like it's a good idea for immune compromised people, those of us who are over 60 or particularly over 70 don't have very robust immune systems. And certainly other countries like Israel are already offering booster shots with the Pfizer and Moderna vaccine, particularly the Pfizer that they use, already to those over 60. So other countries are already doing this. Germany is also starting to sequence in booster shots for older folks and those who are immune compromised. The other part of this is that, again, coming back to the Provincetown group, about 3/4 of those people who did have an infection had some symptoms, usually mild, and didn't require hospitalization. But the other part, and the reason I say go ahead and get the booster as soon as it's available for those of us who will probably be in the next category, those over age 70 or over 60 coming online, because even with mild symptoms, the issue of long COVID or chronic COVID, sometimes called long haul syndrome, can be quite common. And these symptoms are not trivial. And I'll go over a bit more of those. So even though we may have mild illness and stay out of the hospital, there's a significant proportion of us who would have chronic symptoms of this. So the effectiveness of the vaccine I've gone over briefly. And it's also less effective against the Delta variant. So while, again, the Pfizer and the clinical trials and Moderna is similar, Johnson & Johnson is somewhat lower, Pfizer was about 96% effective against the earlier strains when it was in clinical trials. Now it's only about 88% effective against the Delta variant. So yes, we will be seeing more breakthrough infections. And yes, as I mentioned, also the fact that our immunity in terms of antibodies, the first line of defense, is waning over time, and a booster may be appropriate. Again, I should qualify these comments that we at Newton at Home and the rest of the other members of the Health and Wellness Committee, Arthur Glasgow and Cynthia Pill and Herb Plavnik, who is not with us, we try to provide the best evidence-based information that we can find. So I'm, channeling Dr. Anthony Fauci and Rochelle Walensky and those studies and statements from them as best I can here. So these are not my particular views, although I think they certainly make a lot of sense to me. Yeah, 3/4 of those, at least in the Provincetown outbreak, had symptoms. What we don't know from that outbreak, which was quickly assessed, is how many people were asymptomatic. So that really wasn't collected then. So that 3/4 being symptomatic may not be how it plays out for the larger population. I want to quickly give a bit more on this long COVID, because that informs, I think, a lot of the recommendations and why it's so important to not only get the booster, but also in the meantime, take extra measures to keep us all from getting infected in the first place during this interim time, including those of us who are already vaccinated. This long COVID, sometimes called chronic COVID, there's a bunch of other names, long haul COVID, post-acute COVID-19, long-term effects of COVID. The list of conditions that appear and generally occur a bit later, the estimates are all over the map in terms of how common it is, but all of them are pretty high. Some say 20 to 30% of people, even with mild symptoms, will have long COVID or chronic COVID. Others say probably more realistic, it's 10 to 15%. But even that is not trivial. And to put that in perspective, we get pretty animated about a side or a complication of the COVID vaccine, such as Guillain-Barré syndrome, which is ascending paralysis, which does get better in the vast majority. And that occurs at about 1 in 100,000. And you may remember that in the news media a few months ago. Well, 10 to 15% turns out to be 10,000 to 15,000 per 100,000. So long COVID is about 10 to 15,000 times, maybe 20,000 times more common than these rare but serious complications from the vaccine. So we don't talk very much about this chronic COVID, but those people who have had it, and particularly those for whom it goes on for several weeks or months, and sometimes many months, find it really debilitating. And the symptoms that, and this is, I'm reading from this list from CDC just to get this point home. Difficulty breathing or shortness of breath, tiredness or fatigue that can be prolonged, symptoms that get worse after physical or mental activities, difficulty thinking or concentrating, sometimes referred to as brain fog, cough, chest and stomach pain, headache, fast beating or pounding heart, joint and muscle pains, pins and needle feeling, diarrhea, sleep problems, fever, dizziness on standing, mood changes, loss of taste and smell, changes in menstrual cycle, and then sometimes even multi-organ effects that affect the heart, kidneys, and other organs. So, what is chronic COVID? Well, some constellation of those, ill-defined, but when you think about that kind of list and any even 1, 2, 3, or 4 of those symptoms going on, it becomes quite concerning, especially since it's so common, and that Right now, one of the questions we got was, how about those of us who might have breakthrough infections who are immunized? How about long COVID for us who might get infected? There's precious little data out there to look at that, even though it's common and important by all measures. There's no reason to think we would be spared from it. And there's one study looking at the largest hospital in Israel and had good data on their staff who were all immunized and had something like 1,000 breakthrough infections, uh, which was still, um, I think I have my numbers wrong. I think it's 400 some. It was still less than 1% of their staff who had a lot of exposure to COVID got symptoms. But then there was about 9 out of 39, which is about 19%, who had prolonged symptoms. So that's a very small sample in which they say something, but it doesn't really define what kind of constellation of symptoms they might have. And that's about it for what I could find, you know, that's documented. Um, and the key part of that is also that mild symptoms for natural infections also can often be followed by prolonged COVID. And that shifts to another key question that was asked: what about schools and kids, particularly the younger ones who cannot be vaccinated yet? And there's some studies from the UK where they have better data, and particularly more recent times where they've been dealing with Delta outbreaks for longer than we have. And it looks like for the youngest ages, from 2 to 11 years old, about 9% will have symptoms uh, at 5 weeks, and still 7% of them will have chronic symptoms after 12 weeks. So now you're talking about out almost 3 months, and 7% or so, and again, the numbers in the studies vary widely as to how common it is. 7% is still a lot of kids who are still having symptoms that long. And again, they tend to feature many of these same typical long COVID side effects like fatigue, headaches, forgetfulness, anxiety, brain fog, sleep disturbances, loss of taste and smell, heart palpitations, rapid heart rate, and sometimes respiratory and intestinal problems as well. For the older age group of 12 to 16 years old, it's even a bit higher. And again, we know that young people tend to have very mild cases. Very few of them end up in the hospital, and the death rate is low. But 8% of, 13% of those older youth, 12 to 16, had symptoms at 5 weeks, and still 8% out of 3 months were having variety of these symptoms. And the studies are a little bit fuzzy because, you know, what counts in terms of that 8%? Is it 1 or 2 of those symptoms, or 3 or 4? And that varies. So it's very hard to make comparisons, but it's common. I think that's the bottom line. In the US, we've now had 4.2 million children with COVID, which is 14% of the total. So from a practical point of view, as we look at schools reopening, and a lot of those kids who are now unvaccinated and vulnerable, the mandate for teachers and other staff to be vaccinated makes a whole lot of sense to me. Again, protecting these kids, particularly from long COVID, as well as, you know, the rare hospitalization and so on. This highly contagious Delta variant would, by all reason, sweep through schools very quickly. And mask mandates for kids as well as teachers would also make a lot of sense in that context. Likewise, for our, there was some questions about Belmont has already put in a mask mandate for indoors, as did Provincetown early on in their outbreak. And I expect we'll be seeing more of that. Certainly, those of us who've enjoyed some indoor dining are now having second thoughts about the wisdom of that, where you don't wear a mask. And for practical purposes, going to a grocery store or the drugstore, where there's other people, especially if it's crowded, masking up would make more sense to me. Let me just touch on a couple of the other questions that we had. One small one here is, what about the Gamma variant? We've now talking about Alpha, Beta, Delta, and Gamma variants. And this is a renaming system that's been adopted by WHO and now CDC. The Alpha variant is the one that was predominant in the US, came from the UK, and that's why they're relabeling them so we don't talk about the India variant or the South Africa or the Brazil one. The Alpha one is the UK variant, which was dominant up until the early part of June. It was like 80%, and the Delta variant was only 10%. And now, just in less than 2 months, Delta variant is 95%. So it's been so efficient, it's squeezed out all the other major variants that are more contagious than the original strain. The Alpha variant, or UK from the UK variant, the Beta one, which is the South Africa one, and the Gamma, which is the Brazil one, sometimes called P1. So all those are more contagious, but they're currently almost out of the picture because Delta has just overwhelmed those other strains in terms of competing for infections. I'd like to talk about what is safe for Newton at home to do now as we think about giving rides. Is that safe? And what other aspects? And we as a board, I'm also on the board, have not discussed this in detail, and with Maureen, who keeps a sharp eye on these things. But let me open it just for a moment for questions. I've been chatting for a while, and see if you have questions on points that I made or anything that was unclear there so far. If you can just unmute yourself.
Sally Craig, go ahead. And then Cynthia, I saw you raise your hand also. So Cynthia, why don't you go after Sally Craig?
Thanks. Just as you were talking about boosters, Douglas, the thought occurred to me, I haven't seen an announcement yet that this year's flu vaccine is ready, but could you comment about taking that and the importance thereof when it is available?
Yes, I mean, as usual, the flu vaccine is important. We don't know what this flu season is going to be like. Last year, we were largely spared, maybe because we were masking up considerably last summer and going into the fall. And the influenza virus is less contagious, it would appear, than is COVID, even the earlier strains. So that would be protective, but definitely you don't want to get influenza, and especially, a serious case which is more common for those of us in the demographic that I see on my screen here that put us in the hospital. This is not the time when you want to be going into the hospital either. Cynthia.
Well, I have a question, but I want to tag on first to Sally Craig's question. So I've already gotten a phone call actually from Wegmans Pharmacy asking, did I want to reserve for their flu vaccine? So I guess one of the things that I wondered is, taking the flu, which one always does, but then the booster comes out, should there be space between those two when one gets it, or does it not matter?
Yes, for those of us who've been giving vaccines, the COVID vaccine, typically 2 weeks between other immunizations and the COVID vaccine. And probably the same would be the other way around. If you get the booster, one would wait a couple weeks before getting the flu vaccine. Good question.
Thank you. The question that I actually was originally thinking about is many people in our age bracket have grandchildren, some of whom are older than 12, some of whom are younger than 12 or going back to schools. What guidelines would you have for families getting together when there are 12 and under children?
Yeah, I think right now, given the trajectory of this epidemic, I mean, it's just outpacing the guidelines. Caution, extra caution is definitely warranted. And that would mean masks, more distance, less time with those who are unvaccinated. And the reason for that we may be a transmitter is because particularly coming out of that interesting Provincetown assessment, the PCR tests that were done on them can give you a semi-quantitative idea, or gives CDC a semi-quantitative idea of how much virus there is in the nasopharynx where the swab was taken. And it turns out that the amount of virus in the passages of those who were vaccinated and got COVID was about the same as the unvaccinated. So that gives a kind of crude assessment that we may be transmitting more than has been previously thought when it comes to the Delta variant. So that's preliminary, but it seemed to be good enough guidance that influenced Walensky's and CDC's guidance that now we vaccinated people also wear masks when we go into a grocery store or elsewhere where there's other people. And I would extend that to children. I think that makes perfect sense. And again, particularly in light of this long COVID, which is so common in kids, they may not get really sick, but even weeks or months later, they can start having all these other problems, which are really, really tough on kids. I mean, the psychological impact of going from being a straight A student to not being able to write a coherent sentence, you know, is traumatic and devastating. So, you know, those things that we're not talking about very much. I mean, there's some articles coming out in the newspaper, but I think we should take those very seriously. So the same guidance, you know, just as though before, unfortunately, pertains.
Tamara, go ahead.
Douglas, I want to go back to the booster shots for people who are immune suppressed. In the case of, you know, my husband being a kidney transplant, I had read there was some concern that it might have a bad effect on the transplant because it's increasing the strength of the immune system, and therefore you might put the transplant in danger. So you kind of caught. And I don't know if anyone's talking about that or writing about that.
Yes, I have not heard about that. I think, you know, the general guidance, and this may not be helpful for that particular theoretical concern, and I doubt if there's data where you can show that it would or it wouldn't. I think I'd follow the guide. I would be inclined, if it were my kidney transplant, and it's not, to say, you know, to top up the immune response to COVID would probably be overriding the other. And I think that's the general guidance so far. There's not exceptions made for transplant patients. They are in fact included in the current CDC guidance for who might be first in line for booster shots, as they describe the range of immune compromised people.
Thank you.
Allison,
What?
yes.
Hi.
Oh, sorry if I interrupted. Was there somebody else?
Nope, that was just me about to say Allison.
Okay.
How effective do you think the common type of mask that, for instance, I wear in the grocery, the blue pleated masks that you'd get in a box, the disposable ones actually are?
Okay. Yeah, you've touched on a point that I was going to cover is sort of, so what are the other practical steps for us? And you know, a little demonstration if you'll permit. So this is the typical blue kind of hospital mask. Sometimes they have little gaps on the side. So as we ramp up our mask game and do better with that, which is for our own protection, as well as protecting others, sometimes double masking with a multi-layered mask on top of that will help seal it up. And you may be able to see breathing.
Yeah, it makes it hard to breathe.
It makes it more difficult to breathe, yes. And if you can, you know, have a good mask that has a good seal around it, so that you're breathing in through the mask, yes, with a bit more difficulty, that's the way to go. The other way is certainly these KN95 masks, as well as N95 masks, that by themselves have the same effect. Now this one is fogging up my glasses a little bit as I overbreathe there intentionally, but you know, being able to fix the metal strap, these all become key points in protecting ourselves as well as others, as we now have a good incentive to be more careful indoors as well as outdoors around kids, and when we're going indoors. So again, as we learned some months ago, masks can be protective to us so long as we're breathing through them. Outdoors, it's not needed, but indoors where those aerosols need to be filtered out by a KN95 or N95 or multiple layers is the way to go. Not absolute protection, but you know, every step is more important.
So can I ask just a quick follow-up? So in other words, you think that just wearing the single layer blue mask like the one you showed is not really sufficient indoors in a grocery?
They're pretty good. They are pretty good, and you know, especially if you get a good fit. You know, this one works pretty well on me. So I'm breathing in through it pretty well there. So check your mask and see how it does for you. So I mean, these are the simple, practical, and important steps, you know, that we can all do as we get better at protecting ourselves. And yes, from what I understand, breathing in through this mask as well as breathing out through it filters out the virus pretty well, in case we should be an asymptomatic transmitter. So thanks for asking that. That covers that other little point. And again, the other ground rules that need to be paid attention to more, airflow exchange in rooms. If it's a poorly ventilated room, don't be there very long, especially if there's more people. And with a more transmissible virus, you know, 6 feet is not magic. 8 feet would be better, 12 better still, more distance and less time in relation to other people who might be unvaccinated. Okay. shall I move on?
Any other questions at the moment? Doesn't look like it. So why don't you, yeah, go ahead.
Yeah, the question came up, and here's a practical one for those of us, and particularly on the board and our medical committee. What about driving? That Newton at Home has been opening up driving. Is it still safe? You know, well, all this is relative terms. I would say I would be prepared to drive someone, but again, with even more attention to the ground rules, a good mask by the driver and the wearer, making sure everybody's vaccinated, which they are, opening the windows while, if at all possible, making sure that there's rapid air circulation, bringing the outdoors in, and if it's impossible, having the air conditioning or outside air in the car's air system on outside air and high fan to exchange air in the cabin as rapidly as possible, and do all of those things. Obviously for drivers, you know, making sure that you have a mask that's not impeding your vision. You know, some of the better masks also make it a little bit difficult to see, or can kind of get in the way. So, you know, paying attention to all those things. So I think for members as well as drivers at present, if we are going to continue driving, making sure everybody goes by those rules. And obviously, always the mask over the nose as well, which, you know, all those kind of things tend to slip as we become more relaxed. But now's not the time. Arthur. Oh, you're muted, Arthur. Still muted.
Okay. I've driven a couple of our members who don't really have good masks. They have material masks that are not the best. So I fortunately have an excess of masks left over from when I had no idea how long the pandemic would be. So I take extra masks with me, and if I see that their mask I don't think is, you know, the best, I give them one of mine, which are KN95 masks.
Excellent idea. And this may well be something we should consider for Newton at Home and perhaps Cambridge, you know, for drivers and passengers. Yes, everybody's happily gotten a little bit more relaxed, but now, you know, and going back to being more rigorous isn't much fun, but necessary. And frankly, Arthur, I like the idea. You know, it also shows by action the intention that we now need to all be more careful. Yeah, makes sense. So that's, you know, for going forward. Somebody asked me what my crystal ball is, which didn't work in terms of ever projecting that the Delta variant would arrive. But certainly, I think booster shots are going to be in our future for probably the majority of us. And in the meantime, doing everything to avoid infection that we can. An ancillary question that had come up is about, so the Delta variant wreaked havoc in India, as we all read, and then it somehow seemed to go away. Likewise in the UK, it wasn't perhaps the same trajectory, but a lot of infections there, and then it eased up. Why in the world did that happen? Certainly India didn't vaccinate its way out of that peak. So the question is, were there lots of asymptomatic infections, you know, that managed to get up to a level of herd immunity, which, you know, now the guesstimates are as maybe needing 90% of people who are protected either by natural immunity from an infection or with a vaccination. I haven't seen any numbers on that. This is where presumably studies will be coming out, and this is where the serology, looking at antibodies to see if one is likely had an infection in the recent past, would be useful. So maybe those are happening as we speak. I haven't seen them, and epidemics, going back to my experience at CDC, the best epidemiologist cannot always predict or explain why some things happen, why epidemics peak and go down unexplained, and do so at different rates in different places for no apparently good reason. And so I'm afraid, these viruses and other contagions seem to have a mind of their own almost, that's different. But certainly for the US and Massachusetts, watching the numbers go up daily, to be 10, 20 times higher now on a daily basis than they were a couple of months ago is astonishing. So who knows where it's going to go from here, but Dr. Fauci at least says it's going to get worse, and there's every indication. The guidance from CDC, again, on who should be masking, where there's substantial transmission, and now Middlesex County, where we are, and virtually all of Massachusetts is in the substantial risk category rather than minimal. So again, events outdoors when and where you can, and if indoors, making sure there's good ventilation and others. One of the things about schools that's also come up, and particularly in a letters to the editors, why aren't schools talking about their ventilation systems, and particularly filtration devices and filters that can also improve the air quality and filter out viruses, just like KN95 masks can do. And I think that's an excellent question. Again, the air quality for having a schoolroom with a lot of kids who are unvaccinated, and for the teachers with this very highly contagious virus would make a lot of sense. So, and also, just to point out that in Newton at Home, in the office, Maureen has gotten a couple of these air filtration systems, these freestanding HEPA filter, that's high efficiency particle filtration filters for recirculating air in the office, so that where there's one or more people and there's no outside circulation, having this kind of recirculation to filter the air and have it turn over as rapidly as possible inside the office is good. Just as airlines do in the airline cabin with combination of HEPA filters and outside airflow that refreshes the air, complete recirculation every 2 to 3 minutes. So that's why airline cabins seem to be pretty safe places to be, along with wearing masks. Amy, did I miss any of the points that people wanted to be covered?
I don't think so. And I'm just looking to see if there's questions. Not looking for any hands that might be raised.
Oh, Myra?
Oh,
Mariah.
Excuse me.
was it Mariah?
Mariah, yes, sorry. Oh, you're muted, Mariah. Oh, and then Ed.
I just saw my primary doctor, and I tend to get my flu shot early. And she said, please don't wait till October. And that was her advice to me this year for some. And I think she's always been scolding me for getting it too good, because the drugstore offers it so early.
Yes, yes. You know, there's a rational point to that. That the peak transmission for flu tends to be, you know, December, January, February, and sometimes going into March. And so the most robust immunity, you know, would be in the months 2 or 3, maybe 4 months after you get it. So the immunity from the typical flu vaccine tends to drift off also. So getting it before the flu season might start to kick in. Yeah, may compromise your the robustness of your immune response a little bit, you know, when there's peak transmission. So yes, I've heard the same guidance, and I think it makes sense. Ed Selig, then Alan. Ed, you're muted.
Ed, you have to unmute. No, you're still muted.
Alan, why don't you go ahead and then we'll take Ed when he gets unmuted. Hi, Alan.
Okay.
Oh,
Okay.
go ahead, Ed.
Yes, you mentioned that airline cabins are pretty safe. What about a train or a bus? Are those safe these days? We're thinking of taking a train, for example, up to Maine.
Yeah, good question. And I'm afraid I'm not able to give a very definitive answer. I think the air circulation in trains is also pretty good. But again, I would probably wear a mask these days and make sure I'm spaced out. Have considerable distance between me and other persons. I've seen some information, for example, that subway cars, you know, have a pretty rapid air circulation or air exchange rather. But you know, that's hardly a quantitative or a definitive binary choice. Is it safe or not safe? Probably driving oneself would be safer. Buses, likewise, again, you know, I see the school system has been a little criticized too, and there's no guidance in terms of what are the ground rules with a bus. Well, if it were my child, I'd want to have the windows open since they don't have HEPA filters in them and a rapid air turnover, and a lot of spacing and kids wearing masks as well as the driver. So I think those ground rules would apply. It would perhaps depend on the bus. I'm not aware as much of the circulation systems in buses, so I can't answer that. I don't know where I'd look to go for that. I would think intuitively kind of trains might be less risky than a bus, but and again, it would depend on how crowded. Sorry,
I would think
Go ahead.
I would think the red line at rush hour
Yeah,
would be something we should avoid.
yeah, probably. Yeah, especially if it's a lot of stops and you know how people are spaced, and especially now that we're not tuned into really ramping up our overall masking and so on, and there's resistance by some folks, and there's some resistance to getting vaccinated. So you know you don't know who you're around on the red line during rush hour, and that would be a little dodgy. Yes.
I'm gonna actually, Alan, before you go, I tried to send you a little message, but I don't think you saw it. My counterpart, or the person who's kind of like my counterpart over at Cambridge Neighbors, Megan, put something in the chat, so I'll just read it because I was the only one who saw her hand go up. I've read headlines about the Lambda variant making its way north into Texas. Any opinions or comments regarding the Lambda variant?
Yeah, lambda, for those who enjoy the Greek alphabet, in addition to the four variants of concern, as CDC labels them, alpha, beta, delta, and gamma, and really now it's all delta. Then there's variants of interest, eta, iota, kappa, and lambda. So as this pesky virus, continues to shapeshift, particularly that spike protein, there's a lot of different substitutions in the protein that make it more and less effective, as it's trying different combinations. The reasons these are variants of interest and not variants of concern is that they seem to be less contagious than the four big ones that are labeled variants of concern. And for example, the Delta variant has something like 13 substitutions in that the big protein spike form that forms the S protein. And these others have various combinations, sometimes of many of the same substitutions, which are a result of mutations in the virus, but they don't seem to be going anywhere. And I would be very surprised if those others that the real virologists and epidemiologists have rated of lower concern are going to be of importance compared with Delta. Delta is number 1, 2, and 3, way ahead of everything else. And looks like it will be.
Thanks, Alan. Go ahead.
Doug, what symptoms should we be aware of? I mean, many of us, either because of age, might have pins and needles, we might have a sniffle, we may have shortness of breath walking upstairs quite naturally. So at what point do we say, I think this might relate to the virus, and we should perhaps look into it more thoroughly?
Yeah, thanks, Alan. So let me distinguish between, getting infected and becoming mildly ill versus long COVID. So that list of symptoms that I read that can be prolonged in adults as well as children is long COVID. So that's after one is recovered from the initial acute infection. So, for example, the symptoms for breakthrough infections in Israel and also in the Provincetown outbreaks were typical things like a headache, sore throat, cough, little shortness of breath, muscle aches and pains, those kind of typical symptoms like the flu, very, very similar to the flu in many respects. If one had a variety of those common flu-like symptoms and felt lousy, feeling fatigued, get a test. And I would strongly advise the PCR test, that is the one that takes a couple days to get back, rather than the antigen test. That's the rapid test that's now becoming more available and being produced and provided to departments of public health and things like that. The Binax now, I think, is the name of the trade name of it. So there's a lot of these rapid tests out there. They are not very accurate at picking up one asymptomatic infections. They are better at picking up symptomatic compared with the gold standard, which is the nasal swab, the PCR test, which takes a little bit longer. So on an individual basis, if we think we've been exposed and might be having an asymptomatic or symptomatic infection, get a PCR test. The rapid tests are very good for schools to do on a serial basis, even though they're not very accurate at picking up infections. When they do turn positive, it almost surely is truly an infection. So it makes sense to use those rapid tests serially for schools, colleges, workplaces, hospitals, because when you do pick up a positive, you can rapidly isolate that person and everybody else quarantine who's been exposed to them. So that's the public health control measure, which is good. But for individuals who might think you've gotten exposed or that you have some of the symptoms, get a PCR test. Yes, Jean.
I'm trying to get straight in my head when you need to go get tested as vaccinated person, because everything's just so murky. But if you're having no symptoms, but you find out you were, recently close to somebody who ended up testing positive for COVID, should you get tested even though you're not having symptoms?
The changing guidance is yes, you should. Before, those of us who were vaccinated, it looked like we were so well protected, even if we were, around someone, you didn't need to bother. Now the guidance is it's better to be tested.
Okay, thank you.
Alan?
So if you're tested positive, what should you do?
Isolate for 2 weeks. I mean, once you get a positive test back, you will get all sorts of written guidance. But basically, you isolate for 2 weeks until you're better. Some people say, up to 10 days, you're not contagious anymore after that period, and inform others who you've been in close contact with in recent days, or let's say the previous week.
So even though you have no symptoms and you were tested positive, you should still quarantine yourself, etc.
That's right. So you're infected, you may or may not be symptomatic, but we know from previous studies that asymptomatic people spread the virus. So that's why getting tested and isolating is required, really. Am I clear there now? Also, and again, if you have a need to go get tested, there will be detailed written guidance, for about helping others who you might have exposed protect themselves and their families, etc.
Douglas, in terms of testing, are there as many sites available as there were early on? Because I recently heard something on a news program about someone who happened to be in Provincetown. Maybe it wasn't Provincetown. Someone was on the Cape. They thought they might have been in close contact with somebody who had it, but they weren't 100% certain. And they called their doctor, I'd like to come in and get a test. And the doctor said, you don't need a test. You have no symptoms. You don't know if you were close contact. I'm not going to test you. So, if people run into that, which I don't think at this point they will, they still have, local, testing places that people can go into? Can they just walk into one of the urgent care centers and do that?
I think there are, and again, I know when I've been tested for various reasons, I needed a doctor's recommendation or a doctor's order, another doctor's order for a PCR test, at least here in Newton at Newton Wellesley Hospital. I think there's efforts in the local Department of Public Health, whether it's Cambridge or Newton, could give more definitive answers as to where there may be a pre-test that you can just walk in and get tested. I think the efforts are being made to make testing more readily available. And particularly, I know, having been on a call with the Department of Public Health at the state level, that sending out a lot of these rapid tests is making this kind of screening test more readily available. So things are evolving, changing here in Massachusetts. I mean, and this guidance to local health departments was, here's how you order, the Binax Now rapid tests to improve the ability for local testing. So I think probably the best way to answer that, Amy, would be to call the local health department.
Okay.
There may be other options.
Okay. And then Megan actually also wants to know if there's any idea when there will be a downslope to the Delta variant.
Oh gosh, if we all hope and pray enough, it may affect it. But there will be a downslope, but who knows when. Just right now, it's frankly pretty scary. And especially for kids going back to school, and especially, these common, devastating long COVID infections or symptoms that kids are definitely susceptible to. Myra, you're muted.
When I was going back and forth to my daughter's in Connecticut and I had to be tested, I went to the Tufts urgent care in Lexington, right? On Lexington Street. And they were terrific about, they didn't need a doctor's order or any, there was some doctors there. So it was very easy for me.
Well, good. Well, thanks for that. Yeah, I'm sorry. I mean, we're not an expert on where all tests are available, and that might be again where the local health department can give pointers. And things there are changing. I think perhaps even day by day and week by week. Right now, as we head into this upsurge and the fall and additional restrictions. Vaccine mandates, mask mandates. Yes, I think we're going to be seeing more of those. And from a public health perspective, that certainly makes sense. Joanne?
Hi, Douglas, or maybe Mariah can say, or if anyone knows, when you get tested, do you have to pay for it? Is insurance covering it, or what happens?
So far, the ones I've had, certainly insurance covers it. Take your Medicare card or Blue Cross, Blue Shield, or whatever health plan you're on. Typically, it will be covered. And I think there's also now public free testing. And again, whether that's going to be primarily the antigen test or the PCR test, I don't know. Myra, was yours the PCR test that you got?
Yeah.
Yeah. And was there a fee for that?
There was no fee. No. It was Medicare. Well, I'm on Medicare, so I don't.
Yeah.
Yes. Yeah. Typically, it's covered. Yes. I don't know of any situations where you have to pay for it. You can buy these rapid tests at the pharmacy. Now, I think they're coming online and do it yourself. But again, if they're not so good at ensuring that you're uninfected, they don't pick up infections as well as the PCR.
If I may help to answer Joanne's question, Joanne, we've been including locations in some of our Friday e-blasts. And they are the PCR tests, as far as I'm aware, because I've had them done myself. And Joanne, I know we're going to be listing them in this Friday's e-blast too. So you'll see locations around Cambridge that are giving that test, and it is free.
Okay, thank you.
Sure.
Good, thank you very much. Yeah, it would be good to distinguish, Megan, I believe, whether it's the PCR or the antigen test, and some guidance as to the PCR, particularly if you're feeling sick or been exposed to someone, a definite exposure, and you really want to know for yourself and others. If it's just a matter of screening in order to go to New Hampshire or Connecticut, perhaps an antigen test would be sufficient.
Other questions? I'm searching frantically for hands, but I don't see any. Or if you want to ask something, please unmute. Douglas, anything? You have more to?
I think we've covered everything, and I trust, we and the Maureen and we all will have further discussions about, how comfortable are we about driving people, and how comfortable are our members, and how we might up our game in terms of protections and keeping us all safe from infections. I think I've covered most of it.
I'm just going to throw in one more thing that actually came across my screen during this. We had, because somebody asked earlier about families getting together with young children. And then Douglas happened to mention that Israel has already started giving booster shots to people 60 or 65 and over, or immunocompromised. And my family follows the news in Israel quite regularly. And as we were meeting just now, a notification came across that that country expects 50% of new cases to be children once school starts. So I think we're probably not, I imagine we'll see something similar here for the, so I would say, since most of you have grandchildren, please be careful.
Yeah. And, the other point, I guess, the Pfizer vaccine and I think Moderna, there's trials now going on for kids younger than 12. Right now, 12 to 16 is fine. And those kids should definitely get immunized. And hopefully there'll be approval for a younger age group. There's every reason to think that kids will do just fine with the vaccine. They'll develop a robust immune response and be protected fairly quickly. And hopefully that will also be in the future soon.
Arthur?
Hi, Arthur.
I just have one question, Douglas. Do you have any idea what's holding up the final approval of the vaccines?
Oh, yeah. There's so many people who are frustrated at delay at the FDA for not giving final authorization, full approval for the Pfizer vaccine, which is in front of it now. I have no idea. I do know that the drug regulatory process and approval is so extensive. I mean, it involves a lot of assessment of quality control issues at every stage of the manufacturing and procurement and packaging and distribution and those systems, and that's why they picked up that the Johnson & Johnson vaccine was getting mixed up with the AstraZeneca one at this knockoff place in was it Maryland?
Baltimore.
That did a horrible job, and broke the rules and set things back. So it's that nature of things. But my gosh, you'd think with a national catastrophe, you'd ramp up everything and put an army of people to check every nook and cranny of quality. But you pushed my button, Arthur. Yeah, it's very frustrating. It should be fully authorized, and that when it's supposed to be coming in September, hopefully early September, will probably stimulate more mandates now that it's fully approved, and hopefully more people who have been waiting will also get it. Yes, Megan.
Well, I'd never want to say anything that would deter anybody, and the science has shown how effective, it is. But I am somebody who had a really adverse reaction to the vaccine. So
the vaccine.
Yeah, to the Pfizer.
Uh-huh.
And couldn't get the chose not to get the second shot, and 2 doctors backed me up on that because of
Uh-huh.
such an adverse reaction,
Uh-huh.
which is an unfortunate situation because it's obviously doing a lot of good out there. But,
Yeah,
but
yeah.
I am just one little voice in that, perhaps just doing that extra research or whatever to make sure that,
Yeah.
there isn't a bad effect, might not be a bad thing.
Yeah, the short-term, side effect. I mean, and those of us who went through the screening issues for those people who shouldn't get it when giving vaccines, doesn't clear everybody. And yes, there can be unusual reactions, and knock you off your feet. How long was it before you felt reasonably good again?
I'm still experiencing the symptoms, but it's been dissipating. So it's been 2.5 months now.
Uh-huh.
Yeah.
Uh-huh. Uh-huh.
But I can tell I'm on the trajectory of it being gone, hopefully, completely. So, so fingers crossed.
Can you tell us what the symptoms are?
Dizziness, headaches, and bad brain fog. And my mental acuity took a nosedive. A lot of things like that. I have found a website on vestibular. It's a vestibular health website, which is, I guess, a little part of your inner ear. And a lot of people have been posting on that with really similar reactions. So there's like a theory about like an allergic reaction, and a little part of your inner ear, perhaps swelling might be the wrong word. Dr. Huber, you might know better, but anyway, that's one theory, is that just some people are having some sort of allergic reaction and it's affecting some part of the inner ear, which explains all the dizziness.
Yeah, I would think, I mean, the symptoms you described are a little bit like a mild case of COVID. I mean, they go along with that and or long COVID. So that, putting that immune spike protein in your system triggers, all the antibodies. And long COVID, while there's a lot that's not understood, it's presumably, the inflammatory response gets a little bit out of whack, and starts attacking our own systems, that accounts for many of these long COVID type symptoms, and perhaps the kind of symptoms that you experience. And while I'm sure, given the 160 million people who have been fully immunized, there's going to be a variety of things. In the overall picture, I mean, the percentage who get that is extremely rare compared with the percentage who are going to get long COVID. And, and just one final note, for those who are unvaccinated now, there's quite a few reports coming in from heads of departments and emergency rooms that Delta variant is not only more contagious, it seems to be making many people sicker a lot faster. So going from feeling just lousy to needing a respirator, in short order is much more dramatic as seen in the bigger picture, and why ICUs and hospitals are filling up so fast in states where there's fewer people vaccinated. So, getting the disease, particularly the Delta, for unvaccinated, which is 97% of all the hospitalizations now are among unvaccinated. That's a real bummer. So for kids as well as olders, vaccine, in spite of, I appreciate your sharing those complications that are rare. But Alan.
So I'm just curious if in Megan's case, as I understand it, the batch number of every injection is recorded, and whether there's been any research going backwards. I mean, there must be other people who had the same vaccine that day that Megan had, and did they have also similar symptoms? You know, was there a variation somehow in the vaccine that caused some people to have follow-up symptoms, side effects or whatever, and others were just home free, as I was. I had Pfizer also, for example.
Alan, the longer answer to that, which I'll try to shorten, is that there's an army of people at CDC, FDA, and NIH following reports of adverse reactions to the vaccine. And it started out, you know, not only with the 44,000 who were in the trials, but then particularly health professionals in all the hospitals who were first in line for voluntary reporting. So there's a system for reporting adverse reactions across the board that to CDC from any individual about the vaccine as well as providers. So that and they can, you know, certainly if there's a blip of a cluster of untoward symptoms, especially something that wasn't seen before. And that's how this Guillain-Barré, at the rare occurrence of 1 in 100,000, or actually less than 1 in 100,000, can be picked up and attributable to the vaccine rather than coincidence. So there is a lot of detailed tracking, post-marketing surveillance. I mean, we're not in a post-marketing situation for a fully approved vaccine, but all those systems are in place for all the vaccines, and mountains of data being collected and tracked by that. Yeah.
Allison, go ahead.
Yet another question about masks. There was an article in the New York Times a few days ago about how there has been a big, I guess, problem with counterfeit masks, even when ordering from sites such as Amazon.
Mm-hmm.
I don't know if you saw that. Then the person who wrote the article said they provided a very, very long list of what were legitimate masks and suggested scanning with a barcode. I mean, the whole thing's like a colossal nuisance. Are you aware of a major problem with counterfeit masks? And even if one happened to end up with the so-called counterfeit mask, again, would they have significantly less protection? Talking again about these common blue pull-on masks, like demonstrating before.
Yeah. The science behind this is imprecise at best. We'd love to know definitively how much virus and the virus particles are filtered out by masks, and there's, you know, a lot of studies that have been around that, but you know, how effective it is actually at preventing illness and infection is really difficult for people to get a definitive handle on. So unfortunately, I'm not sure how you detect those masks. And again, you know, best we can do is the CDC guidance is, you know, the double masking, the hospital blue masks, presumably from reputable places, you know, the ones that are available at your doctor's office or health providers or stores, as best I know, are pretty good. And even, you know, the double fabric cotton masks, you know, are pretty good. So it almost seems like an art more than a science sometimes. You know, that's a fuzzy way to answer the question, but I'm not sure anybody's got a real handle on which are counterfeit and how bad are they compared with ones that are, quote, not counterfeit. Yeah. I'm sorry, I don't have good answers to that one. I'll look for the article too, and if there's something that comes up that's clear, I'll share it. Barbara.
I could send the link to
Okay.
Megan or Amy.
Great.
You or I don't know, whoever I have.
Sure, to Amy maybe, and she can share it.
Okay.
Hi, Barbara.
Hi, yes, a question about children's masks in school.
Yeah.
Under 12, most kids, excuse me, most kids that I see under 12 have cloth masks. And I'm wondering if there's any attention being given towards making the N95s in a smaller size.
Mhm. I haven't seen that. I would think it'd be a good idea. And I guess by inference, I'm saying as we all up our mask game, that it would be wise and prudent for schools to do so. I'm not sure what the discussions are, by school boards and school health officials as to how they're going about masks. But also just making sure they're worn over the nose and that everybody's wearing them when they're indoors will be probably the name of the effort going forward. And distance, and better air ventilation and things like that, and filtration if it comes to that. No reason why all these measures can't be stepwise increase to blunt what is likely going to be an upsurge of COVID in kids.
But you did mention that the cloth masks really don't do a whole lot by themselves.
It's better. I mean, each step is incremental. A tight fitting, a well-fitting cloth mask that has fine fabric. CDC studies have said that's pretty good. The hospital mask or a KN95 mask is presumably better. Or I mean, again, that's the guidance from CDC. So that doesn't give very precise information. But I think there's a lot of cute masks out there that are thin and comfortable to wear, that are one layer and synthetic, that don't filter out much of anything.
Right.
So avoiding the least effective ones. And there's guidance, again, one can find a lot of information on the CDC website if one wants to go there. And that's what I would hope schools would be doing.
Thank you.
Okay, I think we look good.
All right.
I don't see any more questions. Douglas, I really want to thank you once again
You're welcome.
for all of your research and the time that you spent doing that research and sharing everything with us. It was really very helpful. And I can promise everybody, yes, as things change, we'll schedule another one of these. Perhaps after the school year begins, when we start to see what things are looking like once the kids go back to school, might be the time to get involved again, and we'll make sure that you guys know, everybody knows about it, including our Cambridge neighbors.
Yeah, a lot to talk about these days, unfortunately. So stay well, everyone.
Yeah.
Take
All right,
care.
everybody.
Thanks
Thank
for
you.
joining.
Thank you, Douglas.
Thank
Thanks
you.
for your good questions.
Thank you so much.
Thank
You're
you.
welcome.